Welcome, Representative Hicks, House File 4896. Please proceed.
Thank you so much, Chair. I will be incredibly brief. This bill is appropriation for the pre-planning process to create a psychiatric residential treatment facility, a 30-bed facility for children. Rather than make you listen to me, I will hand it over to the testifiers. First, Ms. Anderson will tell you about the need, and then we'll move to DCT to share the process.
Welcome, Director Anderson. Please identify yourself and proceed.
Good morning, Co-Chairs Fanson and Lee, and members of the Capital Investment Committee. My name is Kirsten Anderson. I'm the Executive Director of Aspire Minnesota, a statewide association of child and family serving organizations. I'm here in support of House File 4896 to invest in safety net mental health care for children by supporting the development of a children's psychiatric residential treatment facility to be operated by Minnesota Department of Care and Treatment. For context, we know that Minnesota needs a full continuum of mental health care to meet the needs of our children and families. Unfortunately, we have too many gaps in our children's mental health system. Kids and families are waiting too long for earlier intervention and skill building. Our most effective treatment models haven't been built to scale, and we do not have sufficient capacity to serve children with the highest levels of need, especially related to symptoms of aggression toward staff, peers, and self-harming behaviors. House File 4896 responds to the needs of our most complex children, children who our system currently fails when they fall through the cracks in care and get stuck boarding in hospitals, detention, and or with counties. In response to the boarding crisis, we as community providers have built a community mental health collaboration hub to bring together clinical experts to identify solutions for children to transition from boarding to community care. As part of that work, we collect de-identified data on children who are boarding. The data are clear. Children who get stuck boarding are children whose top risk factors include aggression, self-harm, and elopement. Children's residential treatment providers statewide are caring for highly acute children today, and the most acute needs continue to outpace our staffed capacity to serve. As hospital, residential, and community mental health experts gather weekly within the hub to identify treatment options for children who are boarding, there are often inquiries about the options that DCT can deliver. As a state agency with expertise in safety net care, DCT is positioned to close the specific gap in our service continuum. As you consider this investment, there are three other realities to bear in mind. First, as the memo in your packet outlines, over the past 20 years, Minnesota has lost over 850 beds in residential treatment capacity. This proposals and other recent projects are building updated trauma-informed and responsive treatment models that are greatly needed. Second, acuity of children and complexity of systems continues to increase here and globally. We need to develop capacity throughout our continuum to meet this trend. Third, this work is full of nuance. Individualized care for children and families is complex. From early intervention to our most intensive responses, we must thoughtfully build a responsive and full mental health treatment continuum, including sustaining critical care being delivered today. There is not one solution. We must pursue many in parallel. Finally, and most importantly, you need to know that despite our system gaps, wait times, and other pain points, we know that when children and families get the care that they need, they do better. Outcomes improve for the short and long term. Children's mental health care improves and saves lives. Thank you.
Welcome, Chief Freeman. Please identify yourself and proceed.
Hi, my name is Nancy Freeman, and I'm the Operations Services Chief Operating Officer for Direct Care and Treatment. Thank you for the opportunity to testify on House File 4896. As Ms. Anderson said, there currently is a gap in treatment resources for children and youth under the age of 21 with complex mental health conditions in Minnesota and across the country. The funding in this bill is a small step forward in the process for the possible development of a 30-bed secure PRTF that will be operated by Direct Care and Treatment in the future. Pre-design and design could take 18 to 24 months to complete. DCT will then request additional construction and operating funds during the following session. Direct Care and Treatment is appreciative the appropriation of any funding that would increase resources for children and youth under the age of 21 with complex mental health conditions. Thank you for your time. Direct Care and Treatment staff and I are available for questions.
Thank you, Chief Freeman. Vice Chair Frederick.
Thank you, Mr. Chair. Representative Hicks, do you know the approximate wait time kids are, like right now, kids that are waiting for these types of services, how long are they waiting? And then if they can't afford to wait, what's happening to them right now?
Representative Hicks.
Thank you, Chair. So the wait time varies, I would say, 3 months to 9 months, depending on the boarding situation. We've had some children who've boarded for over a year. What typically happens, and we send them out of state, and when we send them out of state, counties pay for it with property tax dollars. In 2023, I added an amendment onto the Children and Families Bill to require counties to collect that data for the previous fiscal year. What it showed was that our property tax payers in Minnesota, our county spent almost $80 million sending kids out of state because we could not provide those resources in state. And when they send them out of state, they enter into individualized agreements with those providers out of state, and it comes completely out of the county coffers.
Vice Chair Frederick.
Thank you, Mr. Chair. I guess the second part of my question then would be, does this facility address the entire need for the entirety of the state, or would this just be one of perhaps, or more than one? What does that need look like?
Representative Hicks.
Thank you so much, Chair. So DCT completed a study to give us more information about what the scope and the needs are. We recognize this will not be the only solution. As Ms. Anderson stated, we need a lot of solutions, but we currently have 0 state-run PRFTs, which is why we are sending kids out of state. We only have 1 locked children's facility in the entire state, which means that children who are elopement risks have 1 option in a state of as many people as we have. And so this is step 1. So the first step was to figure out how much money we were sending out of state to meet this need. We got that number in 2024. The next step was to ask DCT to tell us what it would cost and what it would look like if they stepped into the space. We got that report this year. This is the third step to start looking at moving an actual facility forward. Once we get through these steps and start with something, I hope we can have a conversation about what the true safety net would need to look like. Unfortunately, children's mental health continues to have concerns at a speed to which bureaucracy is not kept up. And the needs do not go away if we do not choose to invest in it and we do not continue down the path. The needs continue, and our counties continue to send kids out of state, and we continue to have our counties pay for boarding and make choices that are not best for kids. When kids get sent out of state and counties are footing the bill for that, it's negative for taxpayers. It also has really poor outcomes for kids. When your child is in Virginia, not the state, or not the city, the state of Virginia, how do you do comprehensive family therapy? When your child is in Missouri, how do you transition back in a way that lets those skills that were learned in that facility transfer home? When your child's in Utah, how do we make those things really work when they come home? And the answer is they don't. Many times when we use out-of-state facilities, we do see improvement for a while, and then we're back in the system, and they're back boarding, and they're back on this hamster wheel that we can't get off of. And so this is step 3 in probably a 15-point plan to really meet these needs. But I would ask the committee to consider this tiny little investment to keep us moving forward. Every year that we don't pick up the next step in this plan sets us back 2 years.
All right, thank you, Representative Hicks. Seeing no other questions, I would take that as just closing remarks. Thank you very much.
Thank you.